Hi, everybody, and thank you so much for joining us. Thank you for giving us your valuable time today to talk to you about the dynamic movement assessment. The following presentation is a 30 to 45-minute presentation that is presented to you as a continuing education course. For continuing education credits for this course, you can simply email us at info@aclprogram.com, and I'll repeat this at the end of the conclusion of this course for a bio as well as objectives for this particular course, which you can provide to your local association for CEU credits. We're offering this as a free CEU course, and this is a replay of a presentation that was performed at the Andrews Institute annual football course in Pensacola in 2013, and is a summary of some of our research results that was presented during that course. Today I'd like to talk to you about the fatigue dynamic movement assessment. What does it mean for injuries and athletic performance? My name is Trent Nessler, and I am a physical therapist and practicing clinician, and also the CEO and founder of Accelerated Conditioning and Learning. Accelerated Conditioning and Learning is the founder of both the dynamic movement assessment, the fatigue dynamic movement assessment, and a 396-page e-textbook on movement assessment. And our disclaimer is obviously that we are the owner and developer of the dynamic movement assessment, as well as the author of the textbook. As a disclaimer, I'd like to start out with a couple of disclaimers, and the primary source of our research data comes out from the sports medicine literature, the orthopedic literature, and the sports performance literature. And one of the things that we just like to make very clear is that although the majority of this research is focusing on non-contact ACL injuries, a lot of these pathokinematics that are described during the course of this are also seen with other lower kinetic chain injuries, and we'll talk about that in a few moments. Is that fed really into some of our results with our research. In talking about non-contact ACL injuries, it's very important for us to recognize that that is really a multifactorial related injury. There's a lot of factors that feed into non-contact ACL injuries. And this can be hormonal issues, it can be structural issues, it can be the femoral notch, the size of the ACL, it can be the Q angle, etc. There's also biomechanical and neuromuscular issues. And the focus of our presentation and the focus of our assessment and the focus of our research is really focusing in on those factors that we know that we can change with some form of intervention. And that is really the primary focus of this presentation will be is what is the impact of those movements, of those pathokinematics on both injuries as well as athletic performance. And although our research is being done on females, this is very important that it's understood that this is also a male issue. We also know from the current issue, the American Journal of Sports Medicine 2013 in March, that return to sport published numbers are much, much lower than we previously thought, both for high school athletes and college athletes in return to football following an ACL reconstruction. So this is a very prevalent issue. It's a very costly issue, and it is a common issue. For example, in the United States alone, there's over 250,000 to 300,000 ACL injuries every single year. It is also approaching a $5 billion to a $10 billion healthcare cost annually in the U.S. alone. We also know that 79% of those who suffer an ACL reconstruction will have osteoarthritis in 12 years. We also know that 20% of those who suffer an ACL reconstruction will have a second ACL reconstruction in 2 years. So this is a very prominent issue, and it's primary focus that, or the primary reason that we focus on the ACL. That being said, the literature, the research that we are doing, the movement assessment that we use, it should not be associated only with ACL injuries. It should not be associated only with female athletes, and quite honestly, not even just athletes. This is an issue that affects military. It affects there were some great research studies that were published in the American Journal of Sports Medicine related to military personnel and recruits especially, and the same pathokinematics that are seen in recruits resulting in knee injuries or lower kinetic chain issues. But it's also seen in police department, fire department, as well as IT band friction syndrome to patellofemoral syndrome, and moms playing tennis. Really, it's anybody who is active. One word I would like to say about the pictures and the videos that you're about to see. These are not posed in any form or fashion. You will see them. These are true athletes. Whether it's a high school athlete, a college athlete, or a pro athlete, these are our athletes today. And if you're seeing these movements in these athletes, you can only imagine what you're seeing in our general orthopedic population. So before we get too far, we would like to describe some terms that we use. Several of these terms you've seen in the literature, some of them you have not. So before we get too far, we'd like to describe some of those. First one being a Trendelenburg. This is a common deviation that we talk about or that we see in outpatient orthopedics. It is a dropping of the pelvis. The picture down in our lower right-hand corner right here shows what a traditional Trendelenburg is. Because of glute medius weakness on the stance phase of this leg, the pelvis drops down in this direction. The Trendelenburg, the retro-Trendelenburg, and the corkscrew is basically a progression of glute medius weakness. A retro-Trendelenburg is described up here. These are the individuals who have gotten weakness of the glute medius or proprioceptive issue of the hip, where they have created a subconscious awareness of this, and they actually push themselves over to the opposite side, kind of locking down that hip. The way we describe this is the same as the stroke patient who ends up getting hyperextension of the knee, where they place that femur right on top of the tibia to give it some stability in a hyperextended position. In this position, in a retro-Trendelenburg position, it actually gives the joint more stability by placing it in a more locked position. The glute medius does not have to be as active in order to stabilize the pelvis. A corkscrewing, on the other hand, is the next progression of weakness, and that is really where you get a combination of a Trendelenburg, where the hip drops like this, and a rotation. And those are the folks who cannot control their hip in any form or fashion, and they get this rotational motion. And those are the ones that are at the most most likely to have an injury as a result of this weakness, because of the shearing stress that creates not only at the knee but also at the hip joint. Lateral shift is a common term that we describe of someone shifting their weight from one side or the other away from midline. Well, you'll see several demonstrations of this or several pictures of this, but we name the lateral shift to the side that they shift to. We also call a lumbar pelvic dissociation, and that is simply an athlete or an individual's inability to discern lumbar hip flexion from lumbar flexion from hip flexion. Core movements, that is the term that we use to describe the 6 movements of the dynamic movement assessment. And then pathokinematics we'll describe shortly in just a moment. When we think of the kinetic chain, we're thinking along the entire kinetic chain. And it's all of these components working together that produce productive human movement. It is a fine-tuning and a working together of the nervous system, the muscular system, and the skeletal system. And it's when these systems are not working properly, it's when these systems are not conjoined together, that there's an increased risk for injury due to lack of force attenuation and a decrease in athletic performance due to an inability to produce force or maximal force. When thinking of human movement, most human movement, for example, like a squatting motion, is mostly reflexive in nature. This means that it's driven primarily at the central pattern generator, or the CPG. These are our spinal reflexes. However, there is some component that is provided by the higher centers. Knowing that there is a component provided by the higher centers, we know that these motions can be driven and can be changed in the primary motor cortex. In order for proper motion or ideal motion to occur, there's got to be the proper interaction of all these systems together to produce movement that is productive, efficient, and loads the tissues in an anatomically designed fashion and decreases ground reaction forces. For example, if we take this athlete off to our left here, who's running on the treadmill, we know that her ground reaction forces are going to be much more in line than if the pathological gait. We know from research studies that simply having a pathological gait increases ground reaction forces from 1.1 times body weight up to anywhere to 7 to 10 or 5 to 7 times body weight. We also know that ground reaction forces are increased greatly with jumping versus gait, where some studies have shown that ground reaction forces jump all the way up to 4 to 8 times body weight. When thinking of ground reaction forces and pathological movements, there's not studies that show what those ground reaction forces are with pathological movements, but we do know that they are higher, and we would suspect that they're even much higher than 4 to 8 times body weight. So for the purposes of our discussion and our demonstration today, the lower kinetic chain really refers to anything from the pecs on down to the feet. And the primary reason that we use that is that it's the largest influence on overall lower extremity kinematics, and it's also the largest influence on overall athletic performance. Looking at force production and force generation, the hips, the lower core, and the core itself is a very important component. It's also this lower kinetic chain that is the most impacted by the dynamic movement assessment. When we think about movement and we think about the impact that that has on strength, when we think about the impact that it has on performance, we first have to think about length-tension relationships. And obviously we all know the length-tension relationship curve. We also know that it's based on a bell curve, and we know that if you have a millimeter of change to one side or to the other, that there's dramatic drops in strength that is produced. That results in a decrease in changes in that can result in a decrease in force attenuation, resulting in injuries, as well as force production, which can result in decrease in athletic performance. So when thinking about the strength length tension relationships and thinking about this curve, think about what a lateral shift like this does to a length tension relationship. Now, in the length tension curve, this is simply represents millimeters of change. And when you have an athlete of this nature, and a high-level athlete at that is demonstrating over a 3-inch lateral shift to one side, you can only imagine what that is doing to the length tension relationship, but also the ability to attenuate force, not only through her foot and her ankle, her hip, her knee, but also her lumbar spine, but also her ability to generate force through the entire kinetic chain. When thinking of ideal motion, we think about what is tissues, how are they anatomically designed to attenuate force. Looking at the lumbar spine, for example, we know that 80% of the weight is meant to go through the bone-disc bone interface. We know that 20% of the weight is meant to go through the facet joints. We know that flexion increases at 80% and extension increases at 20%. We know anything outside of that will alter that 80-20 relationship or that ideal loading of the lumbar spine. If we look at cartilage, cartilage is biomechanically designed to resist compression. However, it is not designed to reduce or resist shear stress. Biomechanically, it is placed at a disadvantage against shear stresses. So when thinking both about the loading of the lumbar spine as well as shear forces, think about what a lateral shift like this does, not only at the hip, not only at the knee, but at the lumbar spine. When you see an athlete like this, who is a high-level D1 athlete, soccer player, What does that shifting do to her lumbar spine? What does that shifting do to her SI joint? What does that shifting do to the labrum of her hip? When thinking about pain, we know that tissues are meant to be moved in a certain fashion, and when they're moved outside of those fashions, when they're loaded in ways that they're not meant to be loaded, that this can cause pain. We also know that that can cause weakness, which can also further facilitate weakness, which can further facilitate greater pain. We call that the pain cycle, where you get pain, weakness, pain, weakness, pain, weakness. So when thinking about alignment, when thinking about abnormal loading, when thinking about pain, thinking about this. Again, another D1 athlete, post-fatigue, and thinking about the patellofemoral joint in particular, not only with her stance leg, the leg that she's coming up on, but also the leg that's behind. Both of those are in a compromised position, not only for the patella and the patella riding in the patellofemoral groove, but also the IT band and IT band friction syndrome. And thinking about what that does, not only for pain, but also weakness. So talking about patellofemoral, let's take a look at this athlete. It's a 14-year-old volleyball player who had 2 seasons complaining of patellofemoral pain. Unfortunately, she had seen her orthopedic surgeon on multiple occasions and had multiple bouts of physical therapy. 3 different bouts of physical therapy, 3 different providers. Unfortunately, she was sent back to her orthopedic doctor because she was unable to continue with volleyball secondary to pain. Her doctor had scheduled her for a patellar relocation. 14-year-old girl, patellar relocation. Take a moment to look at the position of her foot. Take a moment to look at the position of her knee. Her knee is almost pointing to midline. And I'm not an orthopedic surgeon, but I would almost beg to say that any patellar relocation that is performed on a patient that is moving like that is not going to prevent her problem. Fortunately, she came to see us, had a dynamic movement assessment, and we were able to create an intervention for her. I am proud to say she is now in her 2nd year of playing volleyball with no pain. She has won 2 seasons as the most valuable and improved player, and this year was named to the national volleyball team, all while avoiding not only patellar relocation, but over $30,000 in healthcare costs that is associated with that. So what does abnormal movement look like? Well, again, I said these pictures are not posed, and it's not always going to look like that. But this, again, is a soccer player that, again, was coming into being seen after receiving a bout of physical therapy and was being released to return to sport. And I would beg to say that not only is she at a great risk for injury or re-injury, but she is also at a great risk for a performance issue. So when considering these kind of movements, thinking about soccer, volleyball, basketball, cheer, gymnastics, baseball, or football, think about the impact that that would have on gait. Think about the impact that that would have during sport, and think about the impact that that would have on athletic performance. So pathokinematics, this is a long term. It's not something that you see a lot in the literature. Matter of fact, you're only now just starting to see this in the literature. But so therefore, we like to define this as we define it, and it's the pathological alignment of the lower kinetic chain during functional activities that results in abnormal force attenuation, i.e. injuries, and abnormal force production, i.e. performance issues. Both of these result in increase in injuries and decrease in athletic performance. It should be noted that this can happen both as a result of proximal and distal components, and a typical presentation can include any one of these or just part of these. But what does that impact on injuries, and how in particular does that impact the kinetic chain on up the kinetic chain? Let's take a look at that. Let's start at the foot and the ankle and see how does these pathokinematics impact performance, and how do these pathokinematics impact injuries. So let's first look at the foot. When viewing these pathokinematics and looking at the foot and looking at this particular athlete in particular, we can definitely see how this can add to plantar fasciitis, Achilles tendonitis, Morton's neuromas, stress fractures, shin splints, and compartment syndrome. As you can see with her during her squatting motion, she drops into a supinated, or I'm sorry, pronated position with acceleration from a low point up to a high point, from that transition point during her squatting motion. For her, this resulted in not only chronic shin splints, but also resulted in, for her as a flyer, is her inability to increase her vertical. Let's look at the knee. How does that impact the knee? With the adduction and internal rotation and or a lateral shift, some of the common problems that we see are patellar tendonitis, patellofemoral syndrome, IT band friction syndrome, meniscal injuries, ACL injuries, unhappy triad, and degenerative joint disease. We're firm believers in the fact that, recent studies show that 79% of those who've had an ACL reconstruction develop osteoarthritis, that if mechanics like these are not corrected, then that will add to increase in risk for osteoarthritis. Here's a perfect example of a 34-year-old Major League Baseball player. Perfect example of someone who is having kinetic chain issues in his history. What he described as developing fatigue later on in the game and then ending up corkscrewing and developing some knee pain. How does this impact on the hip? Both with a lateral shift and or a Trendelenburg or corkscrewing, and corkscrewing being the most dramatic. Some of the things that we see are trochanteric bursitis, proximal hamstring strains, labral tears, piriformis syndrome, sciatica, hip flexor, hernias, etc. Perfect example here is we had a 24-year-old professional ballet dancer, history of low back pain and hip pain, and as we continued his evaluation, you can see that he's got, again, a pretty fair amount of right foot pronation as he does that transition from full squat, from the deacceleration phase to the acceleration phase, but also a significant amount of hip weakness, that once his hip weakness was addressed, his pronation at his foot was also dramatically improved. What is the impact on the spine? This is a young man's a perfect example. Unfortunately, this young man he's a 4 months post-op ACL reconstruction due to college football player, was being returned to sport. Unfortunately, he had 4 months of accelerated ACL rehab in performing squatting motions, and unfortunately performing squats like this here. This is a picture of not only him during the squatting motion, but also an x-ray of what his squatting motion resulted in. And you can clearly see from the x-ray that how this type of lateral shift is going to greatly impact the lumbar spine. Not only his lumbar spine, but also his hip, his SI joint, etc. So some of the common things that we will see with this is SI joint pain, facet syndrome, disc pathology, hyper and hypomobility of lower lumbar spine, as well as muscle strains and sprains. So what is pathokinematics impact on performance? Well, looking at the research, there's speculated that increase in the magnitude of pathokinematics not only increases your risk for injury, but also increases your the impact on performance. So how would this impact performance? Obviously, a decrease in power output, decrease in peak maximal contraction, as well as a decrease in endurance. Studies have shown that. Studies continue to try to show that, and we're going to talk in just a moment about some studies that we have done that kind of summarizes what those roles are. But thinking about that, how does that also impact individual performance, but also team performance? We'll talk about that in particular in reflection on our research study and some of the impact that we've had with our continuing study that we're doing so far. So here is an unpublished study that we did in Nashville using 40 high school athletes. We performed a dynamic movement assessment. We assessed their vertical jump and their 40-yard dash. And what we found was at the conclusion of this study, after doing their dynamic movement assessment, creating an intervention for them, and then from that creating an intervention, doing that intervention for a 12-week period, coming back, reassessing their dynamic movement assessment and their vertical jump and their 40-yard dash. What we found is we had an average of a 4-inch increase in vertical jump, 1.4 seconds decrease in their 40-yard dash time, and a decrease in the magnitude of their deviations that were noted on the dynamic movement assessment. Now, you hear that and it sounds like pretty dramatic results. However, we need to keep in mind that these were 40 untrained high school athletes. Now, they're high school athletes, but they were all untrained. So that being said, the question always becomes, is that a result of improvement on the dynamic movement assessment, or is that a result of taking an untrained individual and training them? And I would probably speculate it's a combination of the two, and hence why we're doing some of the things that we're doing now with our current research study. So pathokinematics in motion. How do you assess this and capture that in the clinic? Because that's where it really matters. Because at the end of the day, I can put that athlete on the table. I can manual muscle test them. I can stretch their hamstrings, test their hamstring length and things like that. But how do I capture that on the table? Because when this athlete was tested in a static state or on the table, her results were much, much different than they were actually tested dynamically. And more importantly, this actually happened later in the game, later at the end of the game. She actually blew her ACL. And how do you test that in a fatigue state? How do you test a fatigue state in a clinical setting? And that's part of what we're going to talk about in just a moment. But before we know what to test and how to test, we have to know what are the contributing factors. And again, just a look back over the last 10 years of research. There's a tremendous amount of research out there on all of the different contributing factors that add to these pathokinematics. And there's a lot of them, whether it's the role of the hip and the hip strength, whether it's proprioception, whether it's core strength and endurance, or whether it's just general endurance. For example, women transport less oxygen than men because of less hemoglobin and red blood cells per deciliter of blood. All of these things fit into this very, very complex problem. And again, goes back to what I said at the beginning of this presentation, and that is ACL injuries has only had a 1.5% reduction in the last 5 years, when all other injuries have had a double-digit reduction. Why is that? Because we're not getting to the complexity of the issue, because we're not getting to the root cause of the issue. So looking at long-term outcomes, here's some of those statistics that I just mentioned. Return to sport is much, much lower than what we thought they were. These are from some recent studies that were published in the American Journal of Sports Medicine. With football, 63% of high school students and 69% of college football players return to sport following an ACL reconstruction. Of those, only 43% return to the same level, and 27% return at a lower level, and 50% of those that did not return because of fear. Looking at pro and college soccer players, only 72% return to sport, and only 36% are playing 7 years post an ACL reconstruction. So the return to sport numbers are much, much lower than what they were ever speculated to be before. And we also know that 20% of those who have an ACL reconstruction are 20% of those also have a second ACL reconstruction within 2 years. And 40% of those who have an ACL reconstruction a second time usually has more and more tissues that are involved, whether it's meniscus, whether it's a MCL, or other tissues as well. And then also the last one that I talked about was that 79% demonstrate osteoarthritis 12 years later following an ACL reconstruction. So this is a big issue. It's a very big issue, and we've got to get down to the root cause. And how do we get to that root cause? So the take-home message, there's a lot of contributing factors that add into this. It's not just a female thing. It's a male thing. It's a female thing. It's a sports thing. It's a military thing. It's an active movement thing. To truly assess all of these factors, we have to assess it in a way that is similar to the athlete, to the athleticism that is required by the sport. It has to be sport-specific or incorporate sport-specific movements. And we know from the research that single limb testing is much more sport-specific than double limb or bilateral. It has to be able to capture the pathokinematics that we know. We know they're not made-up movements. They're not ones that we think. They're not ones that we assume are associated. They have to capture the ones that we know are associated with athletic injury. We have to have a way to quantify these in a meaningful way in a clinical setting that we can do it every day. And the improvements must carry over to the sport. They got to carry over to the sport. They got to carry over to the actual activity. Because at the end of the day, if we can prove it on our movement assessment, but it doesn't carry over to the court, it doesn't matter. And we have to be able to tap into the true athletic profile of the athlete. So how do we tap into that? That depends on the athlete. Sometimes it's just the dynamic movement assessment, and sometimes that's combining dynamic movement assessment with a fatigue protocol. So, and that's exactly what we have done with the fatigue DMA. The fatigue DMA is simply the combination of a fatigue protocol called the FAST-FP. The FAST-FP was published in 2012 in the Journal of Athletic Training, January issue of Journal of Athletic Training, where they compared the FAST-FP with the slow-FP. And the slow-FP is, in simplistic terms, is just the general VO2 max testing. It takes 45 minutes to do it. It takes a lot of equipment to do it, and in a clinical setting, it's not very practical. The FAST-FP, on the other hand, takes about 5 minutes to do. And what the research has shown is not only does it bring an athlete to a fatigue state very similar to a VO2 max, but also that the kinematics that are associated with that fatigue state are actually greater than what you get with a VO2 max test. So based on that, based on the fact that it only takes 5 minutes to do, based on the fact that it is very sport-oriented with agility training, based on the fact that you can do it in any clinical setting with clinical equipment, with stuff that is present in 90% of clinics, is part of the reason that we use the FAST-FP with the dynamic movement assessment. Basically what we do is we perform the FAST-FP and the dynamic movement assessment. We videotape this. It takes 15 minutes total time, and then we score it. Our average D1 and pro athlete rate this an 8 out of 10, and we feel that this enables us to get to or tap into an athlete's true athletic profile. And we say true athletic profile because it allows us to see what do they look like when it means the most. At the end of the game, when it counts the most from both a performance issue as well as an injury issue, it allows us to be able to tap into that state. So the FAST-FP is performed over 4 sets, basically consists of a 31 centimeter step up at 220 beats per minute times 20 seconds, an L drill where cones are set apart 5 yards apart. They perform that. They go right into some counter movements at 78 to 82% of the max vertical jump times 5, and then they do the agility drill. As soon as they are done with the 4 repetitions of that, they perform the dynamic movement assessment. On the average, this takes 15 minutes. Due to us being live on webinar, we will not be demonstrating that for you today. What is the dynamic movement assessment? The dynamic movement assessment is a combination of 6 essential movements. This includes the full squat test, the step-up test, the single leg squat test, single leg hop test, plank test, and side plank test. This is considered a progressive assessment, meaning that each test progressively gets more and more difficult, and that's absolutely essential for 2 reasons. One, it gets progressively more difficult, which adds into our differential diagnosis. Certain movement patterns that we see, that represent themselves on some of the easier tests then carry over to our later tests, which helps us derive our root cause of the problem. At the same time, it is also a progressive test because that leads into our risk rating. We know that if people fall apart earlier on the test, that they are at a higher risk for injury than if they fall apart later on the test. Overall, the test consists of 80 repetitions and 1 minute test, 3 1-minute timed test. So what are we looking for? We're looking for the quality of the movement, range of motion, and that means range of motion, whether it's an abnormal pattern, whether it's a shift, pes planus, adduction towards midline, etc. And we're looking for segmental quality, whether there's hypomobility at the spine, at the hips, at the foot, and the ankle. We're looking for symmetry of the movement. How is the right side compared to the left side? We're looking for initiation of the movement. Where is the movement initiated at? When someone does a step up, are they circumducting with their step up? Where is their movement falling apart? Is it falling apart in the eccentric phases or in the eccentric phases? Because that's going to determine how our interventions are going to be implemented. So briefly, we'll look at 2 of the movements. This is a U.S. Olympic athlete, steeplechase. She's got a 3-year history of left knee pain. At the conclusion of her season, not throughout her season, but at the conclusion of her season, which is an essential time for her because that's where she's moving into nationals and also where she is moving into Olympic trials. So for her big thing is that she wanted to shave off 0.2 of a second. So let's look at her real briefly. First, we'll look at the full squat test. And as we can see, she's got a pretty significant lateral shift. We would call that a lateral shift to her right. We can see that she is shifting her weight over to her right side. If we look at the single leg squat test, again, keeping in mind this is a steeplechase athlete, and we can see when she is going into the single leg squat position, a position which should be power for her with her push off, accelerating over the top of a barrier. She is losing a lot of force production and also increasing her risk for injury. Her overall scoring with some of the movements, as you can see, we can see both from a symmetry standpoint where she lies. We can see some lateral shifting that is occurring at the hips. We can see adduction towards midline and significant adduction towards midline. So our research study, this is has been performed since 2011 into 2000. We're going to continue it into 2014. This year we'll actually be including women's basketball and volleyball. I think I mentioned that just a moment ago, and we'll be talking about that in just a second. This is our universities that participated in the study. We had 2 D1 colleges, 2 D2 colleges, 2 intervention groups, and it was female soccer players 18 to 24 years old, and N value of 102. Our intervention group was 42. Here's some of our data. First of all, this is preliminary data, and we're continuing this study because our intervention group being 42, you're talking about 1 team over 2 years, and you're talking about a team that would traditionally see anywhere from 2 to 4 ACL injuries. So from a statistical perspective, even though we've had a 100% reduction of ACL injuries, you're really only talking, anywhere from 4 to 8 ACL injuries that were prevented. But some very significant data that came out of this one was we did the fatigue protocol. We did a pre-fatigue protocol day 1. We came back 3 days later and performed the fatigue protocol. The mean ratings of perceived exertion for our D1 athletes was 8 out of 10 on the fatigue protocol. The significant thing that was really important for us, because with our intervention groups, we grouped them according to their scores as well as their deviations. And what we found is our grouping would have been dramatically altered had we gone off of our pre-fatigue data. As you can see from our pre-fatigue data, we only categorized 25% at risk and 2% at high risk. However, once we went through the fatigue protocol, we found that 36% were categorized as high risk and only 5% were categorized at risk. Based on our groupings and based on our post-fatigue data, that's what we based our correctives on. We had a 100% reduction of ACL injuries over the 2-year period and a 58.2% reduction in all other non-contact ACL or non-contact lower kinetic chain injuries, and that's from the lumbar spine on down. And when we looked at the number of those, that was actually much more significant. One thing that's not on this slide is that we also had a greater than 60% reduction in number of days on the DL. And that was really important. That was really important because our key players are typically the ones that get injured. Our key players are typically the ones that are on the DL more often later in the season. So it's because they were off the DL, because we reduced the total number of days on the DL, that they were able to perform at a higher level later in the season and able to go into national playoffs with key players. Another really cool part of this was the overall cost savings. Total cost savings over 2 years for one sport, one college, was $200,000 over that time frame, and that is cost savings associated with MRI, physician visits, surgery, and physical therapy. So those are our results. This is the conclusion of our presentation for today. As I said at the beginning of the presentation, if you would like to submit this for CEUs, total time is for this presentation was 43 minutes today. You can email us at info@aclprogram.com and ask for a bio as well as objectives for this course. We can send that to you, and you can submit that for CEUs with your local or national organization. And we can also provide you with a certificate if that is needed. If you'd like more information on the dynamic movement assessment on ACL, please log on to our website at www.aclprogram.com, and you can see on there not only our programs that we offer, the services that we offer, but also if you go to calendar, you can see our up-and-coming certification courses. We do offer certification courses both in the dynamic movement assessment. Level 1 is fundamentals of movement, where we go through normal movement, abnormal movement, and how do you assess abnormal movement using the dynamic movement assessment, and how do you, based on that, create interventions to impact that movement. Level 2 is fatigue and pathokinematics, and in that course we go through all of the research related to fatigue. We go through the female athlete, the fatigue dynamic movement assessment, and then interventions and group interventions to be performed with large groups or teams, and how to integrate this into physicals. So if you're interested in that, you can log on to our website. If you would like more information, there's a contact us. You can either contact us through that or email us directly at info@aclprogram.com. Thank you all very much for your time. We appreciate it. We know your time is valuable. We hope that you found this worth the time and interesting, and we hope to hear from you soon. Thank you so very much, and have a great day.